My name's Eric Morand. I'm the head of rheumatology at Monash Health in Melbourne, Australia, and the chair of the Asia Pacific Lupus Collaboration. Today, I'll be discussing the need-to-know updates to the EULAR guidelines for SLE and lupus nephritis, and how these recommendations could shape how you practice. Many of the resources we discuss during this program can be found at the SLE Clinical Resource Centre online at exchangecme.com. So, what's changed in the world of SLE and lupus nephritis since the 2019 EULAR guidelines? And what's motivated this update? So there's an evolving treatment landscape in the world of lupus and lupus nephritis. After long periods of very little innovation, at last, we've got a cascade of innovations and approvals of new therapies in the last few years. And so the EULAR guidelines group decided that there was sufficient new information and new medications available that the guidelines published in 2019 should be updated. And that was published at the end of 2023. Likewise for lupus nephritis. So let's look at the 5 overarching principles in these updated 2023 EULAR guidelines, because they really form the backbone of the more detailed recommendations. The 5 principles are as follows. Firstly, that management of patients should be based on shared decision-making, including an emphasis on patient education. It should be multidisciplinary and should be individualized to the needs of the individual patient. Secondly, regular assessment of patients is recommended, ideally including the use of a validated measure of disease activity. Measures such as the SLE Disease Activity Index, or SLEDI, and the British Islands Lupus Assessment Group measure, the BILAG, are among those recommended. Non-pharmacological interventions to improve long-term outcomes should receive priority, and they include things like attention to cardiovascular risk factors, bone health, and of course, not smoking. Number 4, pharmacological interventions need to be based on the individual patient characteristics. This is so important in lupus because of the heterogeneity of other disease between one patient and another. But we have to also focus on treatment-related harms, comorbidities, risk factors for organ damage and organ damage itself, as well as patient preferences. And finally, early diagnosis and appropriate treatment to achieve clinical remission in each patient, or if remission can't be achieved, low disease activity, to eliminate ongoing inflammatory disease, prevent flares and organ damage. This last recommendation, that the goal of treatment is remission, was present in the 2019 guidelines, but the strengthening of this recommendation and improved ways to get there, I think, are an important outcome for this revision. How does this translate into concrete, implementable recommendations? Here's one. Antimalarials, specifically hydroxychloroquine, is recommended for all patients with SLE. A target dose of 5 milligram per kilogram real body weight per day. However, individualized based on risk for flares and retinal toxicity. What does this actually mean? Well, in the 2019 guidelines, hydroxychloroquine was recommended, less contraindicated, at a dose no more than 5 milligram per kilogram. The new recommendations refer to individualization. And what I take from that is that sometimes you can use a lower dose in a patient who's doing really well. But sometimes you can actually use a higher dose in a patient who benefits from that while managing the potential risks, especially of retinal toxicity, and having that shared with the patient in a shared decision-making context. So the target is the same, but I think what's changed in these guidelines, it's a bit more real-world flexibility for going slightly above or slightly below those doses as you need to. So what's next? Glucocorticoids. Everybody's favorite and least favorite drug. What's new in these guidelines? So glucocorticoids, if needed, should be dosed based on the severity and type of organ involvement. And here's a really important thing. Should be reduced to a maintenance dose of no more than 5 milligram per day prednisone equivalent. And when possible, withdrawn. This is an important shift in thinking. This is accompanied by a recommendation about the use of intravenous pulse steroids when needed at doses of 125 to 1,000 milligram a day for between 1 and 3 days. And this can be considered in patients with more severe disease. So what are the differences now compared to 2019? Firstly, the recommendation in 2019 was similar, that glucocorticoids are used at doses and routes of administration that depend on the patient's particular problems. This is one of the things that people who look after lupus patients do basically at every visit. Are you on steroids? Are you on too much steroids? Are you on not enough steroids? That's the thing that we're always tweaking. The chronic maintenance treatment recommendation in the 2019 guidelines had a ceiling dose of 7.5 milligram per day, but now that's changed to a ceiling dose recommendation of 5 milligram per day. All these doses I'm talking about are prednisolone equivalent, of course. So in the 2019 guidelines, it was also suggested that supplemental therapy with immunosuppression could enhance the ability to reduce steroid. So where are we now in the 2023 guidelines? I think the change from 7.5 to 5 is a very meaningful one. How has that come about? The DORIS definition of remission, which uses a ceiling dose of 5 milligrams per day, has now been completely validated as showing protection from long-term organ damage, improved health-related quality of life, and reduced mortality. The low disease activity state definition that my group had a role in developing had a ceiling dose of glucocorticoid of 7.5 milligram. That's still better than being on more than 7.5 milligram, and there's plenty of evidence for that. But what we now know is that every milligram counts. So reducing the patient from 7.5 to 5 will have a measurable effect on reducing the long-term harm to that patient from their steroid use. The recommendations also go on to suggest withdrawal of glucocorticoids whenever possible. We know from outstanding prospective studies in patients who don't have active disease that withdrawal of steroids can actually increase the risk of flare when the patient is taking standard of care. But what I think these new recommendations tell us is that we should adjust the standard of care in order to achieve that goal. And that might link us to some of the other recommendations that call for more aggressive or earlier use of non-standard interventions. So, the recommendation in patients not responding to antimalarials with or without glucocorticoids, that immunosuppressive agents, mycophenolate, methotrexate, azathioprine, or biologic agents, belimumab or anifrolumab, should be considered. This is quite a big change in the recommendations, because in 2019, we were saying that we would consider adding immunosuppressive agents, methotrexate, azathioprine, mycophenolate, and consider add-on treatment with belimumab in patients with inadequate response to that standard of care. We might call triple therapy, antimalarial, glucocorticoid, and immunosuppressant. There's a difference now because instead of the biologic belimumab being considered as an add-on in a patient not to that standard, it is now part of the standard for patients in their initial management of disease. This is a big shift. Now, for rheumatologists, we're familiar with the idea in rheumatoid arthritis of treat early, treat to remission, treat to target. But in lupus, sadly, until now, we haven't had the tools to be able to make such a recommendation. But now, with the evidence of belimumab and anifrolumab achieving higher rates of low disease activity, and in the case of anifrolumab also being published to increase the attainment of remission, that the evidence now is strong that this should be considered as part of the initial standard of care for patients not responding to antimalarials alone. So I think it's a very big change and a very meaningful one for how we proceed in looking after our patients. I guess the other part of this steroid recommendation is that we should consider trying to actually have a steroid dose of 0. I know what I tell my patients is that the goal steroid dose is 0, but that it can be hard to get there, and we work together to try. I guess that's what we will continue to do, but I think what we're trying to do is fly those steroids at a lower than ever altitude and use our newer medicines earlier to help us get there. Okay, now skin disease. The recommendation is that treatment of active skin disease should include topical agents, which includes glucocorticoids, but also CNIs. It should include the use of antimalarials and possibly systemic glucocorticoids, although the strength of evidence there is less. And with anifrolumab, belimumab, methotrexate, or mycophenolate considered among the second-line therapy. So you can see here in this recommendation, the use of biologics is listed prominently in the management of skin disease because of the evidence from randomized trials and post-hoc analysis, as well as many case reports now coming out, that biologics, especially anifrolumab, are very effective in the treatment of active skin disease. So I think this shift to the early use of targeted therapies for skin disease is really a meaningful one. So, lupus nephritis now. The recommendation is that patients with active proliferative lupus nephritis, and proliferative here means class 3 and 4, should receive low-dose urolupus IV cyclophosphamide or mycophenolate, either of those with glucocorticoids, and the recommendation is for intravenous pulse methylprednisolone followed by lower oral glucocorticoid doses. That's quite similar to the old recommendations, but there's a change here, which is that combination therapy with belimumab or a CNI, such as voclosporin or tacrolimus, should be considered. Now, the reason for that is that both belimumab and voclosporin have had successful phase 3 clinical trial programs and have now been approved by regulatory agencies in various parts of the world as add-on therapy for the treatment of active lupus nephritis. The trials were done with the addition of those therapies as part of the standard of care. They were not done in patients unresponsive to standard of care. So we should be thinking about the combination of antimalarials, glucocorticoids, immunosuppression such as mycophenolate, and a CNI or belimumab as part of the standard of care for the initial therapy of lupus nephritis. Now, can we do that in every context, in every patient? We go back to our guiding principles. It's individualized care in conversation with the patient, thinking of their comorbidities, risk factors, and other aspects of their health. But the recommendation is to consider this stacked combination in the initial treatment of lupus nephritis. So what about the continuation of treatment? So following response to therapy, treatment should continue for at least 3 years. Now, this is based on follow-ups from long-term follow-ups of patients showing that shorter durations of therapy are associated with unacceptable rates of recurrence of active disease. But what should that maintenance therapy be? It depends how you started. So in patients initially treated with a mycophenolate combination, you should continue. So if you started on antimalarials, glucocorticoids, mycophenolate, plus or minus belimumab or CNI, then that is the treatment package that you should continue on, of course, with tapering of glucocorticoids, preferably to 0 if possible. In contrast, if your starting treatment was a cyclophosphamide combination, then after response to therapy, that should be replaced with mycophenolate or azathioprine form maintenance therapy, again, for a duration of at least 3 years. These are different because of the availability now of voclosporin or other CNIs, as well as belimumab, as add-on therapy to the previous standard of care. Emerging evidence which will continue to emerge about the optimal duration of therapy, and of course, going back to one of our principles, lowest possible doses of glucocorticoids. I'd like to direct you all as well to the recently published KDIGO guidelines for the management of lupus nephritis, which are very similar and give it a little bit more detail about recommendations, for example, of lower doses of intravenous pulse steroids, lower oral starting doses of steroids, such as 0.5 milligram per kilogram rather than 1 milligram per kilogram, and targeted tapering approaches. So, what about in patients who are in remission? If this is the goal of treatment and we get there, what do we do now? Now, nothing makes me happier than seeing a lupus patient in remission. The only thing I would rather see them in is in remission with a lower treatment burden. The recommendation now is that patients who achieve sustained remission, gradual tapering of treatment should be considered, prioritizing first the withdrawal of glucocorticoids. Most patients who've had severely active disease are on triple therapy with hydroxychloroquine, glucocorticoids, and an immunosuppressant or biologic. So which of those should you taper first? The answer is the steroids. And the reason for that is because of all the evidence of harm of long-term exposure to glucocorticoids. So if I have a patient who's in DORIS remission on 5 milligram of prednisolone plus antimalarials and mycophenolate, which one will I reduce first? Assuming all other things are equal, the thing to do first is the glucocorticoids and maintain the other therapies. This was not addressed at all in the 2019 EULAR guidelines, I think because the concept of sustained remission being sufficiently frequent that we even had this question to address was just not really there. And isn't it great that now we're talking about patients in remission and what to do then? There are 2 more videos in this series that I'm excited to be joined by my colleague Dr. Marta Mosca. In these next 2 videos, we'll discuss in more detail how to individualize management of your patients who have lupus and or lupus nephritis, based on the detail of these updated recommendations. Please think about subscribing to Exchange CME's YouTube channel and check back regularly for updates and new videos. And finally, for additional opportunities, don't forget to have a look at exchangecme.com for more materials. Thank you very much and see you next time.